All right, well, hello everybody. Thanks so much for joining. My name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative. Thanks for tuning into this webinar entitled the Pre-Hospital Trauma Care for the Musculoskeletal Trauma Patient in Resource-Limited Settings. We have a packed agenda and only an hour to get through it, so we'll jump right in. But for those of you who are joining us for the first time, just as a quick way of introduction, the Harvard Global Orthopedics Collaborative is a group of Harvard-affiliated orthopedic surgeons, faculty, researchers, trainees, all dedicated to improving access to musculoskeletal healthcare globally. So we put on these webinars, we do conferences, we do research, we work with local partners in several different countries around the world to develop systems of trauma care delivery. And today we're learning about something really, really important, which is about pre-hospital trauma care, specifically the musculoskeletal trauma patient. So with that, I'll hand it over to Peter. Just before we begin, though, just a couple of housekeeping items. If everybody could please mute your microphone while speakers are speaking, just so that we don't have unwanted noise. Please do, if you would like, have your camera on. It's always nice to see smiling faces rather than blank screens. And of course, this session will be recorded and will be available to all once it is completed. So with that, I'll hand it over to Peter. Thanks very much.
All right, thanks so much, Karan. As was stated, welcome to our session today, pre-hospital care, musculoskeletal trauma patients in resource-limited settings. My name is Peter Delaney. I am a medical student at the University of Michigan Medical School, as well as the executive director of LFR International, a nonprofit that seeks to develop emergency medical services in resource-limited settings. I'm also a researcher at the Michigan Center for Global Surgery, as well as a member of the United Nations Road Safety Fund's platform on health and road safety. So as a bit of a background, injury comprises 10% of global mortality, as many of you I'm sure know. This is disproportionately borne by low and middle income countries, which represent 90% of global injury. And then the single largest contributor to this global injury burden is actually road traffic incidents. These represent the top 24 of 25 countries bearing the largest dailies burden from road traffic injuries. And this also poses a significant economic burden, taking an estimated 3% from these countries' GDP as a result. Currently, Africa is projected to suffer the highest growth in mortality, followed closely by Southeast Asia. Some of the factors that contribute to the road trauma burden, which contributes to the global injury burden, are due again to road infrastructure, urban development, industrialization, lax enforcement, differences in training protocols, as well as licensing procedures, and then just the booming population growth as well, outpacing infrastructure. And so along that injury control spectrum, on one side, you have surveillance. You have to measure a burden before you can address it. Included in that is also prevention, which comprises some of the preventive measures that might be taken with seatbelt laws, helmets, things of that nature, or road safety. But in the case in which prevention fails, management is necessary. And that comprises trauma systems. An important component of trauma systems are emergency medical services or pre-hospital trauma development. Included or estimated in DCP3 was that 54% of the current annual 45 million deaths in LMICs could be addressed with an expansion of emergency medical services. When EMS is not available, it's been found that 80% of injury-related deaths occur in the pre-hospital setting, as opposed to just 59% in high-income settings with EMS. As of most recent survey in 2017, published in Pre-Hospital Disaster Medicine, just 9% of the African population had access to emergency medical services. Unfortunately, trauma, though, does remain the weakest link on the survival chain, as few context-relevant guidelines exist. Unfortunately, it's not just as easy as replicating what currently exists in other settings. as this has consistently failed for both financial reasons, infrastructural reasons, and insurance reasons. As a result, development has both been varied and highly incongruous. And you'll often see of existing ambulance services that inter-facility transport predominates, not so much picking up patients from the scene of an injury and bringing them to definitive care. And so as a result, since 2004, the World Health Organization has recommended training bystanders as the first step toward formal EMS development, but there still exists no blueprint to take these layperson trainings to formal EMS programs. And so that's where a lot of my team and our research has been focused on alternative EMS development utilizing pre-existing transportation providers, namely motorcycle taxi providers. We've trained more than 5,000 motorcycle taxi providers across 5 countries, including Sierra Leone, Uganda, Chad, Nigeria, and Kenya. We've focused mainly on curriculum development, efficacy, as well as retention of both skills and knowledge, and then studied rates of decay, as well as changes in emergency care coverage and what happens when you equip some of these trainees with dispatch. Finally, we've also studied cost effectiveness. Our main findings in just over 2,000 patient encounters has been that when equipped with a list of 4 contraindications for when you can't transport someone by motorcycle, in over 90% of cases, victims of road trauma were able to be transported by motorcycle. In a sort of self-sustaining sense, we also found trainees earned 24% more than their untrained counterparts, which incentivized continued voluntary participation. We found after 3 years that 3/4 were still involved. And for describing the novel socioeconomic incentive, we were actually awarded the Prince Michael International Road Safety Award in 2020. We've also found that the model significantly expanded pre-hospital transport, that it's been highly cost effective. So we're now studying both how one might coordinate LFRs better with emergency medical dispatch software, as well as programs. So now we're going to hear a little bit more from our panelists. First, from Dr. Chikotho from Malawi to describe her experience both with pre-hospital trauma care development, epidemiology, as well as some of the solutions she's been working on. Dr. Chikotho.
Thank you. Let me just share my screen. My presentation is on pre-hospital trauma care in Malawi, but before I go into the details about pre-hospital trauma care in Malawi, I would like to briefly discuss the burden of trauma in Malawi, as well as in the end, I'll briefly discuss the opportunities that I see that they are there for the improvement of pre-hospital trauma care in Malawi. So Malawi has one of the highest road traffic mortality rates, estimated at 33.4 per 100,000. And up to 20% of all trauma that presents to different hospitals is due to road traffic collisions. Road traffic collisions are also responsible for severe trauma, both for admissions that are for patients that are admitted in the hospitals, as well as for patients that are brought in death, as close to half of these patients are due to road traffic collisions. This is a slide that is quite familiar to most people. All it says is that injuries are responsible for much more deaths compared to the most common infectious diseases combined. And this graph just puts the road traffic fatality rate in context. As you can see, Malawi's rate is above the average for high, middle, and low income, respectively. In terms of musculoskeletal trauma, the burden is huge. For femoral shaft fractures alone, it is estimated that about 5,000 people every year do get femoral shaft fractures. And studies that have looked at trauma registries have found that over a third of all patients who present with trauma have fractures. In Malawi, most of the fractures are treated non-operatively as opposed to operative treatment, even in those cases where there is clear evidence that patients with fractures end up with musculoskeletal impairment. Operative treatment is associated with high mortality as well as poor quality of life and function. Provision of emergency care in the pre-hospital setting may help to reduce mortality as well as reduce the risk of disabilities associated with trauma. It is estimated that 80% of injury deaths in low and middle income countries occur in the pre-hospital setting, as it was already presented, and that close to half of these deaths could be prevented. In Malawi, there is no countrywide emergency response system. Since 2019, May 2019, there is a pilot emergency response system that is run by the Ministry of Health in 6 districts out of the 28 districts of the country. So in this system, people who have witnessed road traffic collision can call a toll-free number, and ambulances will come on the scene and respond to the but this is only done in 6 districts out of the 28. There is another emergency response system which is private and only accessed by those people who have medical insurance. However, over 90% of Malawians do not have medical insurance. So pre-hospital trauma care in Malawi is largely provided by lay persons. These are the people who are the first responders. And these people have no system of communication with the hospitals. So they cannot alert the hospitals that there is an emergency coming. In terms of mode of transport on the scene, the people who are the first responders just find whatever transport is available, and it is mainly public transport or private cars that take the patients or the victims to the hospital. A small proportion, very small, do have attended by an ambulance. There have been 2 studies that have been done in Malawi to assess the knowledge and skills of these first responders. One of the studies looked at the community members, and the other study looked at people who bring these victims to the hospital. So it was a hospital-based study. And what was found in both of these studies is that the main goal for these first responders is to identify rapid transportation to a hospital, because they are not comfortable to provide any intervention. So provision of intervention on the scene is not a priority. And in terms of who are these first responders, they are varied. Most of them are people who are small-scale businessmen who run their businesses along the road, but they're also somewhere unskilled laborers, and a small proportion were police officers. I will explain about why there's just a few police officers later. And what they found, the studies found, is that very few people, only 18%, had had some form of first aid training. But the majority of these people had expressed interest that they would like to receive some training regarding roadside assistance. In terms of the interventions that are provided on the scene, these vary depending on the duration that it will take for them to find transport to take the patients to the hospital. But some of the interventions that are provided on the scene include stopping bleeding by using bandaging the bleeding sites with clothes or other fabric, splitting injured limbs with tree branches, or trying to search the victim to be able to identify the victims, but also contacting the police. Now, these first responders use their personal cell phones to contact the police. And there is a problem there, because it means that there has to be someone who has enough phone credit to be able to call the police. And sometimes it is not. So both studies identified some challenges, and these challenges were the challenges that were presented by the first responders. And one of the challenges was that there was a lack of leadership to coordinate the response on the scene. So to the extent that sometimes the first responders spend time on low priority areas. For instance, in Malawi, people do not like to see dead bodies. I guess it's the same everywhere. So what happens is that whenever there is a collision and there are some dead bodies, people would start by removing the dead bodies on the scene first, rather than helping those people who are victims who are still alive. But also because of lack of training, they said that they lack confidence, and therefore that's why they don't really want to provide any interventions, because they are afraid that they might cause more harm. They're saying that fuel is the most important fluid in pre-hospital trauma care. Perhaps this saying is much more true in the Malawian setting than elsewhere, because what happens most of the times when people call the police do not present to the scene immediately, or they don't present at all, because most of the times they give an excuse that they don't have fuel in their cars to come to the scene of the injury, of the accident. And also there were the challenges that sometimes, most of the times, people are not able to provide any further treatment as they are taking the victims to the hospitals. So now, building on, so in summary, by first responders who have not received any training. Now, this is an informal structure, but I feel we can still build on this informal structure, on this existing system, by training these first responders. And this could be drivers, they could be small-scale businessmen, community members, whoever provides first response on the scene. They can be trained to provide safe, basic life support, but also provide them with some resources, and that is likely to reduce mortality and morbidity that is associated with trauma. So these are the two articles that I referred to, the papers. They are both available online. You can check if you want to get more details. Thank you.
Thank you so much, Dr. Chikota. We're going to immediately move in to hear now from Dr. Musali, who is a graduate of the Harvard-affiliated EM residency and also a fellowship graduate from MGH, and is the primary founder of Trauma Link, which is a community-based emergency medical system for victims of road traffic injuries in Bangladesh. Since 2013, he's been the recipient of multiple national and international awards, as well as funding from major donors. We're excited now to hear from Dr. Musali.
Thanks very much, Peter. I appreciate it. Great. Thank you, Morgan. So I really appreciate the opportunity to be able to talk about our work, and very much enjoyed hearing about Dr. Chikota's work as well. So I'll start by providing, if you would, next slide, please. I'll provide just a little bit of context about Bangladesh. It's a country of about 163 million people. It's in South Asia, bordered to its west and north by India. It's one of the most densely populated countries in the world, and recently became a lower middle income country. It's also has some of the most dangerous roads in the world. There was a large national survey conducted a couple of years ago that suggested about 22,000 deaths and close to 3.5 million injuries on the roads every year. It's really important to note in this context that most of these victims are young men. So these are often family breadwinners. And for that reason, the ripple effects of these crashes are often quite profound and multi-generational. Next slide, please. As Peter and Dr. Chikota alluded to, in many developing countries, traffic injuries and traffic congestion are increasing quite rapidly. That's certainly been the case in Bangladesh over the last couple of decades. The country is becoming more affluent, and that's increased the demand for movement of both people and goods. And the infrastructure has just not nearly kept pace with that increased demand. So we see a very high density of diverse road users traveling at different speeds, and that creates very complex traffic patterns that are very difficult to predict and almost impossible to control. You can also see from this slide that there's a very high percentage of vulnerable road users. So these are pedestrians, bicyclists, rickshaw occupants, people who don't have a protective shell around them and are therefore more vulnerable in crashes. There's very little enforcement of traffic laws and a lack of good data to help drive rational and effective countermeasures. Next slide, please. Unfortunately, in this setting, there are no organized pre-hospital services in Bangladesh. So traffic injury victims frequently need to rely on bystanders who often lack training or medical equipment. And despite their best intentions, Good Samaritans can sometimes actually cause more injuries. The problem is compounded even further by the fact that Bangladesh has some of the most extreme traffic congestion in the world. So getting ambulances to and from the scene is often very difficult. And ambulance transport for these victims is actually a rarity. So because, and also once patients get to the hospital, there are often not a lot of resources available for them. Many of these small local hospitals will have a 2-bed rudimentary emergency department, but no surgical services. So because of all of these factors and because of the extreme time sensitivity of trauma, many of these patients die and die unnecessarily. I want to emphasize that many of these patients are young and otherwise healthy people. So if you can get to them quickly, you can prevent a lot of these unnecessary deaths. And that was really our goal in establishing TraumaLink. So we understood coming into this that Bangladesh is a very complex situation. The context is extremely different and that we could not simply transplant an American-style emergency medical system into Bangladesh. Next slide, please. We knew that to develop something that would work in this context, we would need to grow it from the ground up. So very early on in the course of things, we reached out to as many stakeholders as we possibly could. And there are many because road safety affects almost everybody. But we used those meetings as opportunities to really ask a lot of questions and really listen and really learn and to solicit ideas about possible solutions, to ask for very honest feedback about the model we were proposing. And the result of that was that because of all these really good, honest discussions we had, we kind of battle tested the model before we ever went live with it. And so when we did roll out, it actually worked very smoothly. Another very important consequence of this was that because we reached out so early, so aggressively, so respectfully, there was a lot of stakeholder investment in this project, a lot of buy-in, a lot of pride. And I can't emphasize how important that's been in getting us through many hurdles over the last few years, especially these last couple of years with the pandemic. We have not had any volunteers leave the service, even though everybody was offered a chance to do that. Next slide, please. The model that we developed was one where we identify volunteers in these local communities. These are people who live and work by the side of a highway. We give them a day of pretty intensive hands-on training in basic trauma first aid. This happens in classes of no more than 15 students. So everybody gets individual attention from a physician trainer. We provide them with first aid supplies. We have a 24/7 call center that's staffed by professional operators. And we have an emergency hotline number that's widely advertised in these communities. Excuse me. So the way the program works in practice is that if somebody is injured, a bystander will call the hotline number. The operator will collect information on where the crash occurred and how many patients have been injured. And as soon as that information is entered into our graphic user interface, the software program will automatically dispatch volunteers based on their proximity to the crash scene. And because that's an automatic process, that frees up the operator to call police and fire services if they're needed. When the volunteers get to the crash scene, they use the supplies that we provide to treat the patients. And when patients are ready to be transported to the hospital, we provide guidance on the nearest appropriate facility based on where the patient is, but also how severely injured they are. Next slide, please. We went live with this model at the end of 2014, and we've been in continuous operations since then. Next slide, please. Since we started, we've been able to expand to 170 kilometers on 3 major highways. We have 690 volunteer first responders working for us. And we'll expand another 20 kilometers and add 80 more volunteers within this next week. We are approaching 2,100 incidents. We've treated about 4,000 patients, and we have never missed a call. We've got a 100% response rate. Because, next slide, please. Because we've created this hyper-local emergency response system where we have about 4 volunteers per kilometer, they're very well positioned to quickly learn about these incidents. So our response times are very quick. We have people at the scene within 5 minutes, almost 90% of the time. And if we look at our patient demographics, next slide, please. you can see that the majority of these patients are young men. It's about 64% who are men between 21 and 40. And the vast majority of these patients are young. So again, eminently salvageable patients if you can get to them quickly. Next slide, please. One of the, oh, I'm sorry, this didn't come out as well as I had hoped, but one of the concerns about the model was whether layperson first responders could make accurate triage assessments. What I was hoping to show with this slide is that they actually do a very good job of that. All of the patients who were identified as having severe injuries by the first responders were later admitted to the hospital, every single one. And those decisions to admit were made after independent assessments by hospital staff. Next slide, please. We don't independently provide any transportation. We rely purely on the community for this, but the model has worked very well. We've been able to find transportation for every one of the 2,350 patients who has needed it, and 96% of those patients are getting to the hospital within the golden hour. Next slide, please. I will just wind down with some pictures of our volunteers in action, but I'm looking forward to the discussion after this and answering any questions that you have about our work. I appreciate it. Thanks.
Thank you so much, Dr. Musali. That's fascinating work with TraumaLink that you're doing. It's brilliant. We're now going to hear from Mr. Goulet, who's a paramedic instructor, as well as the director of the Emergency Medical Institute at the Palestinian Red Crescent Society in the West Bank. He both manages all EMS activities, as well as trains doctors, nurses, EMTs, and volunteers in ALS, international trauma life support, and first aid at both the national and international level. We're excited to welcome him to speak today. Mr. Goulet.
You're welcome all. It is nice to present my humble slides, humble knowledge in front of you all. We're talking about trauma management in limited resources setting, especially in Palestine. Here we have a special circumstances that we can be present them through the upcoming slides. Next, please. Yes, the Palestine Red Crescent Society is the national society. It is a member in the International Federation of Red Crescent Societies. It provides different services in Palestine, including the EMS. EMS, emergency medical services, we are providing that in Palestine through 33 stations, 600 professional EMTs, and 150 ambulances. We have other providers, governmental and private sector, that are providing emergency medical services as well. Annual EMS total cases treated or managed by our service in the PRCS are almost 130,000 victims. Different kind, 35% from them are trauma cases. Emergency medical services guidelines we use to deal with our cases based on American standards. We teach our students, our EMTs, curriculum based on the American Heart Association and the American Academy of Orthopedic Surgeons and the International Trauma. We have a special case here when we are talking about limited resources, that we have feel that we are really overwhelmed comparing to the number of victims and our resources. It is the Great March of Return. What's that? It is a huge prolonged demonstration. It was established at the fence between Gaza and Israel. These huge number of people were demanding the end of Israeli blockade and their right to return as the refugees. The result was, through that, 116 martyrs who were killed, 35,000 and more injured, almost 20,000 or 54% attended the hospitals. Others were treated in the field, 40% and more live bullets were injured. Next. From that number, we need to focus on the musculoskeletal injuries, particularly limb injuries. As you see, 122,000 injuries were in limbs, 63% of total injuries. So it is almost 2/3. 4,003 live bullets, almost 40% from total injuries. 158 complete amputation limbs distributed like this. 124 lower limbs amputation, 4 upper limb amputation, and 30 hands, fingers amputation. Next, please. Our intervention in this special circumstances was based or distributed in four stages. The first one is field evacuation. The second, the ambulance stage. The third, mid stage, and the fourth and last was the hospital stage. Let's go through these. We were talking about the field evaluation or evacuation. It is considered that the context that we are working in was so complicated with high risk to our volunteers and our staff. Difficult access that may take longer time because of difficulties related to high risk threats to the victims or to the EMT's lives. Priorities was safe and rapid extrication and control bleeding. We cannot do more at this stage because they really were under fire. Next, please. Continue the field evacuation. As you see here, they try to control bleeding, but they are not fully successful to do that. Next, please. This high risk was not really a joke. It was very serious that we have losses for medical staff. 776 were really wounded and 133 ambulances were partially damaged through this event. Next, please. When it comes to the ambulance, which is the next stage, now the evacuators bring here the victim to the ambulance. So this is the next stage. Here, our priorities is to control bleeding and to do a kind of initial splinting and to attempt IV administration, fluid resuscitation or something like this. Next, please. This ambulance used to transfer victims first to the advanced medical post. What is the advanced medical post? It is the third stage, which is a kind of a limited field hospital that are put in or established in a safe area beside the emergency venue. Next, please. What do we do there to continue and assure bleeding control? Ongoing limb assessment, splint, and continue IV administration, and take the transport decision. Next, please. Transport decision meaning transfer those victims to the hospital. Hospital, which is where they can receive the definitive care that they are really needed. So in the hospital, when we transfer those victims, the treatment plan was controlled by two issues. The first one, the number of injuries. So if there is a lot of number of injuries, they cannot spend a lot in the operation room to do more for the limb. And the other, the resources availability. If they don't have adequate staff, doctors, surgeons, nurses, and others, so the decision will be different. So two decisions. The first, amputation, and the other, reconstruction. Based on the upper 2 points, if we have less injury and enough resources so we can go for reconstruction. If not, so they go for amputation. That's why we have a lot of amputated limbs resulted from this tragic event. Next, please. These are the resources for our data for this presentation. I tend to focus for just the single event that's really added to our normal work in trauma and other medical cases. We are serving the whole Palestinian people, almost 5 million people in West Bank and Gaza. So how can you imagine, additional to their normal life with traffic accident, medical cases, heart attacks, CVAs, strokes, and others, you are burdened with this kind of injury. So it is the real limited resources case that can be taught to the others and even to ourselves. We always learn from these events to correct our mistakes, to go forward to the next event with new ideas, with better performance, with less harm to our staff as just as we can. So that was all for my folks. Thank you for listening.
Thank you so much, Mr. Goulet,
You're
for
welcome.
that incredibly compelling both work and impact that you've been working on there. I wanted to thank all of our panelists, obviously, for the time they took in putting together their presentations. Obviously, with Dr. Chikotho discussing both the musculoskeletal burden from both an epidemiologic perspective as well as the first response. Dr. Musali with his work in Trauma Link in Bangladesh, addressing road traffic injuries, musculoskeletal burden there, as well as obviously we just heard from Mr. Goulet with his work in Palestine as well. I'd now like to invite any audience members who may have questions to participate. Again, you can follow us on Twitter at Ortho Global, as well as please check out the YouTube channel at Harvard Global Orthopedics Collaborative. It looks like we may have a hand raised from Batul Hassam.
Yes, thank you so much. Thank you to all the panelists for their presentations. I had one question regarding, so it was identified that training bystanders is essential in any EMS system, but especially in developing countries. Do you find that one challenge is, taking curriculum that was mainly developed for a Western audience and then applying it to, and then making sure that it is applicable in that context? I wonder what your experiences are with that.
Maybe Dr. Chikotho or Dr. Musali might be interested in immediately responding to that question. I would also feel comfortable contributing some as well if they would prefer not to. Dr.
Linda, I
Musali?
can let you start and then I can chime in.
Thank you for your question. I'll just respond. We haven't had, there has been some training for the community members for first aid training, but the curriculum has to be tailored towards the needs of the people. I mean, you cannot just take a curriculum that applies to the high-income country participants and just transfer everything to a low-income country. It won't work. There are a lot of things that are different in as much as they are all looking at addressing trauma, but there are a lot of things that are different and therefore it won't work. But it has to be tailored towards the people who are going to use it. For instance, we do know in low-income countries like Malawi, we have limited resources. And so there are some things that are in the curriculum that are needed to be used. For instance, like splints, we don't have those splints. So they have to be, we have to find local alternatives, if I can put it that way, that will work for us, a setting and not just transfer everything that is in the curriculum from high-income country to a low-income country. Thank you.
Thanks. I think Dr. Chakotay summed it up beautifully, and I'll just reiterate that that's been our experience in Bangladesh as well. One of the challenges that we faced was trying to make the program as inclusive as possible. We knew that if we set very rigid standards for prior medical training or literacy, that we might have difficulty finding and maintaining our volunteers. So the onus was on us to create the curriculum in such a way that it could be understood by people with any level of literacy and not necessarily any medical background. We do the training in Bengali. It's taught by a Bangladeshi physician. We created the curriculum in concert with Bangladeshi physicians. And we also have a training video that we put together that's in Bengali. So the volunteers can use that to learn and reinforce their skills, especially if they're not literate.
Thank you very much, Dr. Musali and Dr. Chakotay.
Ibrahim, in your setting, you were mentioning that you use a lot of the resources from American trauma organizations, including the American Association of Orthopedic Surgeons. Do you use that directly in English? How is the training done for your staff?
Okay, well, actually, the American Academy of Orthopedic Surgeons textbooks, they have a fantastic textbooks related to the whole emergency, starting from the first aid, ending to the paramedics level. So it is a series, so you can build up over them. We have started using that more than 20 years ago when we have established the idea of the Emergency Medical Institute. In fact, it is difficult to transfer that immediately in its own language, English, direct to our students. We work very hard to make a kind of summary and conclusion, try to translate it either through the presentation or before presentation and provide it to our students, because the idea is not learning them English language, but telling them how to deal in the field and save more lives and alleviate suffering from people. So we make two things: take the whole ideas from this large textbook and make a glossary and summary of them, translate it to our students, preserving the language that contain medical terminologies and etc., which should be remain in English. So this is the main textbook that we use. Additional things we use to the trauma, we use the International Trauma Life Support. We in Palestine are an official branch to the International Trauma Life Support Organization based in America. So we teach their textbook to our students, but this kind of education is really directed toward only trauma cases. Whereas the American Academy of Orthopedic Surgeons include all kinds of emergencies: trauma, medical, pediatrics, obstetrics and gyna, all kinds of emergencies. So the major book is the American Academy of Orthopedic Surgeons. When we are going to a certain kind of injuries, chest trauma, head trauma, trauma arrest, we use the International Trauma Life Support material and the textbook.
Thank you. That's helpful. The other point to Batul's question that I thought was interesting was also the cultural elements of this, right? I mean, one thing that we've seen a little bit now in the literature is that a lot of educational materials are in the West designed for a lighter skinned audience, a lighter skinned patient population. That's one thing, right? So black skin, darker skin, brown skin is not depicted in a lot of these diagrams or descriptions of disease, right? So the simple thing, assessing anemia in a patient who may be internally bleeding, it's well documented in Western literature how to do that for a white patient, but not necessarily how to do that in the Malawian context or Palestinian context or Bangladeshi context. So that I wonder if you guys have run into issues like that, educational materials that may not be culturally appropriate. And Linda Chakotay, Dr. Chakotay mentioned the cultural issue of, you know, people not wanting dead bodies on the street, so taking the dead bodies, but leaving the people who are still alive. You know, sometimes there are cultures that are the exact opposite of that. I know that in the United States, the Navajo Nation, the Native American population there, they actually have an aversion to touching dead bodies. So there's a tendency to bring patients who are not dead yet to the hospital and leave the dead bodies, things like that. So I wonder how these sort of cultural issues affect the dispensation, the creation of trauma care systems, pre-hospital trauma care systems for you guys. Anybody can answer that. Ibrahim, John, Linda, whoever would like to take that question.
Actually, this is the real problem. Nonetheless, we are teaching our students, our community to the kind of triage, our professional emergency technicians, always every course, which is a prolonged course, I mean the EM course, EMT basic, which sometimes lasts for 1 year. They have a session about the mass casualty incidences and triage. We are using the START triage system, which was being created in California in the late 80th of the last century, if you know. But we still find that through the culture, when the community start dealing with this kind of accident, they tended to start with the most miserable case and try to evacuate it regardless if they have life signs or not. They think it is a kind of respect and should give an honor to this dead body, not leaving it to the last chance. So this is a kind of tradition, habits that may be changed, but it is difficult to be changed suddenly upside down. We are working very hard on that, especially when the first arrivals to the scene are from our volunteers or first responders, the case will be different. But if it is from lay people who are not having any kind of first aid training, the case that they will start with the dead bodies, unfortunately.
John, any thoughts on that?
To overcome that, we need to continue training volunteers, first responders, distribute and disseminate this culture that the dead has been, the died person has been died. We need to give a chance for another one to survive. This is the idea.
Triage, very, very important. John, do you have anything to add to that?
Yeah, I'll just make a couple of quick points. One is that we did make a point of including Bangladeshi models in our training curriculum. We did feel that was important. I'll just make, so we also faced similar issues with, patients who were eminently going to die being prioritized first. So that was one of the lessons that we had to treat with mass casualty triage, was just that that concept of trying to do the most good for the most people, even if some individuals were sacrificed in that process. That was definitely a process of education for us as well. And it's related, but not directly, but I will say that with our women volunteers, that was a particularly important issue for us to address. We felt very strongly about engaging women in the project and knew that we were working in a fairly conservative Muslim country where there were many cultural and religious barriers against women touching men that they're not related to. So we made very early efforts to reach out to the religious community, to local community leaders. We actually will sit down with individual family members and address any concerns that they have. And by doing all of that, we've actually had very good success with holding on to our women volunteers. We don't have nearly as many as I would like, but all of the ones that we have stayed with us, and the only ones that have left because they married and moved. We had one die, unfortunately, but everybody else has stayed with us. We haven't had anybody leave because they're not being supported, because they haven't had support at home, because they're dissatisfied with the work. But that was a lot of time and effort that went in on the front end of things, and it's reaped benefits. I'll just say it's really important to do that stuff early on. It's harder to go back after the fact and fix stuff like that.
That actually leads me to another question, if you don't mind, Peter. From all of your talks, you guys bring up issues related to retention and accountability of the staff that play a role in the systems that you guys have described. So Ibrahim, you described the safety of the emergency medical responders, right? I can imagine that if your life is at danger in danger, when you're providing this care, it must be very difficult to have the bravery to actually be in the line of fire. So I wonder if you could speak a little bit about the motivations of the staff members that you work with and how they stay working in such challenging circumstances and how you keep them involved. And then for John and Linda, I wonder if you could speak a little bit about in your systems, in your settings, how you develop accountability. So John, you described using volunteers. How do you retain those volunteers in the long term? How do you make sure that they're doing the right thing? How do you continue your training of these folks? And Linda, you mentioned the issues of accountability with the cops, with the police, who don't want to come because they don't have petrol, who come up with excuses and don't arrive on time, perhaps. Is there a way to create accountability structures where people who are supposed to be doing first responding are doing it well and achieving certain targets and milestones? And so that's really a question to all of you. But why don't we start with Ibrahim, and then we can go in the same order I listed John and then Linda, if that's okay.
Okay, well, actually, staff safety is our major concern. Always when we start the presentation and we will finish it, we are telling them that your safety is #1 priority. So it is not the matter how to motivate them to still or to remain providing the service. We are complaining how to make a kind of suppression to them, to be less keen, to be less enthusiastic to go to the field. We are always teaching them that bad consequences that may let them or may face them if they proceed without any counting to the situation. So the problem here that when they get involved in the field, they have a kind of ambition and they can go to the field without counting the consequences. Here, we need to remind them that there is the lines. You should never proceed or exceed them in order to maintain your safety, because your safety is our safety and our responsibility. So if we are sending you there to save people, that doesn't absolutely mean to lose your life or to put you or to endanger yourself. So our concern is to make them less enthusiastic, more rational. This is what we are facing with our staff and our volunteer. And in fact, the more stuff is learned, so if you see the EMT basics is more enthusiastic than the EMT intermediate. And EMT paramedics are more realistic.
Yeah.
Simple volunteers and first responders are not counting anything. So they may become injured or victims easily rather than well-educated EMTs. So it's a matter of education. How long you educate, how time you spend to educate your people, I guess the results will be better in all directions, not only in this matter of safety.
And I guess mentorship plays an important role there too.
Yeah.
John, is that similar to what you've experienced in your training?
Yeah, very much so. Very much so. I'm nodding enthusiastically listening to all of this. Yeah, retention is a big issue, and it's a major concern among people, potential donors or people, who you're trying to get to buy in with this project. But our experience has been that if you choose the right people, there are often a self-selecting group of people, like people who work at busy intersections who have taken it upon themselves to do this work. We seek them out. And if we can find good people and we treat them well, we hold on to them. We worried about incentives. We have not found that to be an issue at all. There were enough intangibles. People become heroes in their communities. They get a lot of social status. They have this very palpable sense that they're doing the right thing. All of that's really helpful. And we also, we support the volunteers. If they have a difficult call, it's not unusual for our field staff to go and spend a couple of hours with them, just talking to them about the experience and just sort of talking them down. And we arrange group meetings between these first responders so they can discuss their experiences with each other. Ibrahim, I'm sure that you've run into this where first responders have a difficult time relating these experiences to people who don't really understand it. So we try to foster the sort of environment so everybody can sort of heal together and support each other.
Linda, can you share some insight from the Malawian perspective about accountability and retention of folks who are participating in these sorts of things? Like, is there a role for volunteers, as John's system in TraumaLink has demonstrated? Would something like that work in a setting like Malawi?
Thank you. I'm sure it will work. So the Malawian situation at the moment is different from what John is describing in Bangladesh, because they have a group that mentor the volunteers. But in Malawi, most of the first responders are just well-wishers who have witnessed a collision on the scene, and they just feel that they should help. They are not mentored at all. They are not recognized. They just do it because they feel they have to do something. And in one of the studies, when they were asked why they do what they do, they just, most of them said it's because of, in English, I think we can say it's the notion of shared humanity. We call it Ubuntu in local language. They feel that as human beings, they need to help other human beings who are in need. If they're okay to help, then they should help. And that's what motivates them. So I feel if they can be mentored, if they can be trained, they are more likely to continue doing what they are doing, because then they know better what to do and they are well equipped. They are able to do what they do when they haven't received any training. So if they can be trained, I'm sure they can do more, but at the same time, they will keep doing it because they keep doing it anyway, even without any training. Thank you.
Great point, Linda. And I think I can't remember who made the point during their talk about how important training can be, because sometimes a poorly trained bystander can do more harm than good. And so training not only in triage, but also in basic, spine stabilization, pelvic binding, tourniquet application, things like that, really important. And Linda, I wonder, from your perspective in Malawi, I just imagine if a bystander, learned how to put on a tourniquet, would that do more harm than good? Depending on how quickly that patient could be transported to a local hospital. Do you get sort of what I'm getting at here? Like there's sort of the bystander's role integrates into the trauma system's role as a whole, and so all things must be considered. And so if you're training bystanders to do something like respond to the scene and put on a tourniquet or something like that, then you have to have a hospital nearby where they can take that patient so that they can be stabilized definitively. Can you speak a little bit about any of the three panelists about sort of mitigating the harm that a well-intentioned bystander may play, doing the appropriate training, integrating that into your thinking about the system as a whole? Linda, since it's based on your last comment, I'll let you comment first if you have anything you'd like to say there.
Okay. Thank you. Application of a tourniquet in a low resource setting is tricky. I mean, firstly, even in the hospitals, most hospitals do not have appropriate tourniquets. And so if you give someone who has had minimal training, unless you train them very well, that this is what should happen and this should be applied within this period. Remember, these people are people who do not have access to prompt transportation to hospital. They are depending on whatever they are going to find, and you don't know at what point they are going to find transport. Now, if they keep that tourniquet for too long, then that is going to cause more harm than help. So I would be very cautious to let the bystanders train them in applying tourniquets. I would rather train them to apply maybe pressure dressing. But in terms of a tourniquet, in a setting where you are not sure about transportation to the hospital, I would be very cautious. Maybe if I would do it, then I would emphasize that it has to be applied within such a time and at such a pressure. And if they're still not in the hospital, then it has to be released and something has to be done. But I wouldn't just leave it free for all, I would say that. Thank you.
Yeah, thanks, Linda. Ibrahim, I see you were nodding. Did you have something that you wanted to add to that?
Always we focus on our volunteers more than what not to do, rather than what to do. So it is better sometimes we said that frankly to them and explicitly through our trainings that it is better sometimes to do mistakes. And remember that the treatment for difficult injuries should be there in the definitive treatment in the hospitals. So you can wait till proper transportation can be done. Initial mistakes cannot be corrected even in the highest professional hospitals if it was a fatal mistake. So sometimes we need to warn them for the consequences of from kind of intervention, but while waiting some minutes, especially if there's a nearby, an ambulance station, it is way better to wait for that.
John, did you have something that you wanted to add to that? I know that we're running towards the end of time, but if you had something to say, I'll let you say it.
Yeah, exactly. I'll just make it very quick. I just think, it really emphasizes the importance of learning the context that you're working in, because you need to identify what needs to be done, but also potentially harmful practices that you can educate people against.
Yeah,
or educate people out of.
Right, and integrate into the system that is there.
Yeah.
One thing that I've certainly learned from the 3 presentations that all of you guys have made is that, you can't do something in isolation.
Mhm.
You have to think about the context, and also you need to think about building the context in multiple ways. So if you build pre-hospital trauma care and bring these traumatized patients to the hospital, but you don't have a hospital that can manage these patients, then you're not really saving any lives. So, I think Ibrahim made that point, Linda made that point beautifully as well. Yeah, thank you. Peter, I'll hand it over to you to sort of take us to the end here. We're a few minutes over time, but thank you all for sticking around.
Absolutely. Well, again, echoing the same sentiments, and one final plug as well. Both be sure to follow us on Twitter at OrthoGlobal and YouTube at Harvard Global Orthopedics Collaborative. Thank you so much for the invitation as well to help co-moderate today. It's been a pleasure to join everyone, and look forward to any potential collaborations and future discussions that may arise from the discussion. So thanks again to all our panelists and for everyone for making time in the middle of a busy day to join us from all around the world. Thanks, everyone.
Thanks very much.
Thank you. Goodbye.